I'm Meredith Taylor Bates, the president of the Association of Adventist Women. Welcome to Vespers. Isn't this an amazing sculpture? The first time I saw it, I was compelled to reach forward and seek my own healing at the hem of Jesus' garment. This is a remarkable woman, because in those days, when you had an issue of blood, you were unclean, and everyone you touched and everywhere you sat was unclean too. Initially, that meant that she couldn't do a lot of things, but that as time progressed, she couldn't shop. She had so many complications. She couldn't go to church. She couldn't run her household. Eventually, she was compelled to break the rules so that she didn't starve. It was a big risk. Touching Jesus was a bigger risk. How did he respond? He told her that her faith had made her whole. Essentially, he told her that the risks that she was compelled to take to satisfy her faith were correct. And of course, that his forgiveness trumped her uncleanliness. Today we're talking about health care and how it's unevenly applied. Our speaker is Dr. Sherma Charlemagne Badal. She has her PhD in social policy and social relations from Loma University, and she became the director of the Masters in Public Policy at the Loma University School of Public Health. There she received a large grant to improve access to all people in San Bernardino County. She's currently a cardiac progressive nurse at Johns Hopkins University and a consultant on healthcare disparities. I have the pleasure of facilitating the panel today. I have my PhD and my MD. I did my pediatric training at University of California, San Francisco, and I have my PhD in cell physiology. I was the clinical director of medical microbiology at Loma University. There I taught the medical students about coronaviruses, among many other things. Let's bow our heads. Dear Jesus, Master Healer, please be with our land. Be with those who are developing vaccines and working on health treatments. Please be with the healthcare workers at the bedside of ill people. Restore their energy and let them think clearly. Please be with those who create health management decisions for our communities. And especially be with those who are ill and have lost loved ones. Let them know that you always want health to prevail. Amen.
Hello, I'm Pamela from Sydney, Australia, and I'm the coordinator for the 10,000 Toes campaign, an initiative of the South Pacific Division Health Department. In the South Pacific, we are facing a pandemic, and its name is not COVID-19. Sure, we've got that pandemic as well, but we have a much more deadly problem, and it's called diabetes. 2 years ago, Dr. Chester Kumar, a surgeon from the Solomon Islands, returned from leave and shared the sad news that over the break he had lost 2 more colleagues in their 50s who had died due to complications of diabetes. He went on to say that during his years of being a surgeon back in his home country, Solomon Islands, a good percentage of his work was spent in performing amputations, not from accidents, but lifestyle related. This shocked me. I personally knew about diabetes because it had taken the life of my grandmother when my dad was just 6 years of age. So yes, I knew from a personal perspective the impact that diabetes had on families. But that was 75 years ago. Here in Australia, we have a health system that detects diabetes very early on in a person's life. So amputations and death are not usually connected in the same sentence. As the conversation continued, we grabbed our computers and started researching the data and discovered alarming stats. As we deep dived into the research, we discovered very quickly that diabetes was impacting lives in a terrible way, right here in our own backyard. The Pacific Islands were in trouble. Statistics are revealed that every 20 minutes, day in, day out, amputations were occurring as a result of poor lifestyle choices. People had moved away from their traditional foods and their way of eating. Families were leaving villages, seeking work in the city. Exercise was on the decrease, and there was a major need for awareness and education on all these fronts. We decided right then and there to put our foot down and start working towards turning the tide on diabetes. The name of the campaign was born out of our desire to save 10,000 toes from future amputations. Many exciting things have occurred over the past 2 years, and I want to share now with you a video that we've put together to show where we have come from and our direction for the next 12 months.
At 10,000 Toes, we know that you want to live in a world free from sickness and disease. The problem is, because of poor healthcare and miseducation, in the Pacific, 80 people are amputated every day due to diabetes. When people lose limbs, they lose employment, children have to stop school to take care of parents, and families struggle to get enough food to survive. We believe it's not fair that 75% of deaths in the South Pacific are due to type 2 diabetes and its complications, especially when this disease can be prevented and even reversed. We understand and have seen the devastating results of type 2 diabetes. That's why we have spent the last 2 years educating hundreds of medical professionals and are providing screening kits to over 600 villages to reach more than 20,000 people. We have also signed an agreement with the Solomon Island government for the rollout of the 10,000 Toes strategy. Here's our approach. Our first step is to provide screening kits for early detection of type 2 diabetes, so amputations, blindness and other complications can be prevented. Step 2 is to run community-based education programs to prevent, arrest and reverse the diabetic pandemic sweeping across the Pacific. Our last step is to upskill health professionals to better manage complications, wound management and rehabilitation, as well as provide a more whole-person health approach. Next, our aim is to supply screening kits for an additional 500 villages, educate over 1,000 people through lifestyle programs, upskill 100 health professionals, mentor more than 500 ambassadors, and begin operating 2 mobile clinics in the Solomon Islands and Vanuatu. But we need you to make it happen. Your donation can put children back in school, food back on families' tables, and give employment, opportunities and purpose back to life. Donate now at 10,000toes.com. When you save a limb, you save life.
We live in uncertain times, but we can use our wonderful health message as an entry wedge into communities that would otherwise keep us at arm's length. The 10,000 Toes campaign is part of the Discipleship Ministries team and is a wonderful way of involving everyone. we have an ambassador training component that is open to everyone from all walks of life, and as ambassadors they can journey up the 5 levels that gives them opportunity to look into the 7 dimensions of health. The 7 dimensions, looks and helps people grow socially, mentally, spiritually and physically. The 10,000 Toes is a way for us to prepare the soil and plant the seed for a very exciting future in uncertain times. This is Pamela from the 10,000 Toes campaign.
Hello, hello, hello. I am so excited to be speaking with you today. My name is Dr. Sherma Charlemagne Badal, and welcome to this week's Vespers. I pray that you and your family are safe and well in these uncertain and trying times. I am grateful to Dr. Taylor Bates for the invitation to speak with you today, and I pray that my presentation will be a blessing to you. Today, I will be speaking under the topic, Creating Health in Uncertain Times. Let us say a short word of prayer before we continue. Father in heaven, thank you for your love and your mercy towards us. Thank you for gathering us here together, even though we're not physically present with each other, but we are here showing up together to hear your word, to hear what you have to say to us. Help us to have receptive hearts and give us the courage to do your will. Amen. So permit me to share with you a little bit about myself, just to provide some context for how I have conceptualized this topic. I am a public health expert, starting off my public health career as a postdoctoral fellow with the Adventist Health Study in the Department of Epidemiology at Loma University. After completing my postdoctoral fellowship, I served as an assistant professor of public health and the program director of the Health Policy and Leadership Master of Public Health program. And at the same time, I also served as a special advisor on health equity, all for the School of Public Health at Loma University. While at Loma University, myself and my dear colleague, Dr. Edward McField, we were awarded a $1.158 million grant to expand access to healthcare for marginalized groups in San Bernardino County. San Bernardino County being the county within which the city of Loma Linda sits. That grant later expanded to almost $2 million before the end of the project. After leaving Loma Linda, I served as a Maryland State Public Health Chief for healthcare quality for long-term care providers and commercial health plans in the state. And that was before expanding my expertise to becoming a cardiovascular nurse, which is the capacity I currently work in at Johns Hopkins Hospital in Baltimore, while also doing some public health consulting. You see, my work has always been about improving the health of populations, particularly marginalized and otherwise vulnerable populations. And there are many other Seventh-day Adventist men and women like me who has built their lives and their careers around the health professions, particularly because we understood that the health professions was our way to reach the world for Christ. As I made those decisions about work and study, I always did so because of my understanding and belief that health was the avenue through which we as Adventists would reach the world for God. And no, this isn't my idea that I came up with out of thin air. In fact, it's based on the writings of one of the pioneers of our denomination, a woman like you, like me, not an ordinary woman, a woman who spoke as inspired by God. A woman who spoke God's truth about race relations in the church, even when it was unpopular. A woman who was willing to pay the price for doing so, because in her own words, quote, "I do not mean to live a coward or die a coward, leaving my work undone," end quote. This same woman of God, Ellen G. White, said, quote, "Again and again, I have been instructed that the medical missionary work is to bear the same relation to the work of the third angel's message that the arm and the hand bear to the body. Under the direction of the divine head, they are to work unitedly in preparing the way for the coming of Christ. The right arm of the body of truth is to be constantly active, constantly at work, and God will strengthen it. But it is not to be made the body. At the same time, the body is not to say to the arm, I have no need of thee. The body has need of the arm in order to do active, aggressive work. Both have their appointed work, and each will suffer great loss if worked independently of the other. End quote. Ellen G. White, Testimonies to the Church, Volume 6, page 288. When properly conducted, the health work is an entering wedge, making a way for other truths to reach the heart. This is Ellen White again, quoting from her writings. When the third angel's message is received in its fullness, health reform will be given its place in the councils of the conference, in the work of the church, in the home, at the table, and in all the household arrangements. Then the right arm will serve and protect the body. Ellen G. White, Testimonies for the Church, Volume 6, page 327. As a church, I believe that we believe this and held onto it. And many of us have been educated, trained, and worked in areas where we sought to use the health work as the entering wedge, making the way for other truths to reach the hearts of those we serve. In fact, as an organization, we have spent millions of dollars and countless volunteer and paid hours creating and sustaining initiatives around the world aimed at bringing health to people in high need, low resource areas that we hoped to use as an entering wedge for other truths. I believe that for a time we perfected the art of packaging health, healing, and the gospel to those in need of physical and psychological restoration. I have firsthand knowledge of this. While in India with a group of Loma University students and faculty in the summer of 2014, we spent 2 weeks conducting health fairs in the slums of India, delivering talks and holding meetings with government public health officials, church leaders, and workers all about health. After our scheduled activities were over, myself and 4 nurses who had joined us from Malaysia traveled from Mumbai to Delhi just to explore a little bit more of India. During our time in Delhi, we took a couple of days to visit the city of Shimla, or others call it Simla, which is the capital of Punjab, best known as the summer capital of the British during their rule in India. You're probably familiar with its beauty from the British drama series Indian Summers. It took us about 4 hours by train from Delhi to Kalka, and another nearly 4-hour drive up the steep, winding road before we arrived at our destination. The further up the mountain we got, the colder and more foggy it got, and the more we had to avoid the trucks carrying the thousands of apples grown in the area because of its climate. We were so high up at one time that it was clear enough for us to see the outline of the Himalayas. And it is up this mountain that we found the Shimla Sanitarium and Hospital in operation since 1914, an Adventist hospital located on that mountain, 7,000 feet up. I believe is testament to our belief that the health work is an entering wedge, making a way for other truths to reach the heart. This is also the reason why our schools have been focused on preparing an army of health professionals in nursing, medicine, dentistry, pharmacy, and even in the allied health professions such as speech-language pathology and audiology, occupational therapy, respiratory therapy, physical therapy, nutrition and dietetics, and public health. So we're back at public health, my area of expertise. According to the American Public Health Association, quote, public health promotes and protects the health of people and the communities where they live, learn, work, and play. While a doctor treats people who are sick, those of us working in public health try to prevent people from getting sick or injured in the first place. We also promote wellness by encouraging healthy behaviors. From conducting scientific research to educating about health, people in the field of public health work to assure the conditions in which people can be healthy. That can mean vaccinating children and adults to prevent the spread of disease or educating people about the risks of alcohol and tobacco. Public health sets safety standards to protect workers and develop school nutrition programs to ensure that kids have access to healthy food. Public health workers track disease outbreaks, prevent injuries, and shed light on why some of us are more likely to suffer from poor health than others. Allow me to repeat the last phrase. Public health works to track disease outbreaks, prevent injuries, and shed light on why some of us are more likely to suffer from poor health outcomes or poor health than others. In other words, one of the main things that public health professionals do, a public health professional, of course, being one of the health professions whose work we believe can be the entering wedge to our truths, is to understand why some suffer ill health disproportionately. In other words, why do health disparities exist? Fortunately, every health profession is interested in uncovering and addressing health disparities. In fact, whole foundations such as the Robert Wood Johnson Foundation has been, created to do just that. Entire bodies of work have been published. Degrees and other types of certifications have been developed for persons who are interested in studying health disparities. Entire schools and departments, and people have made an entire career out of just studying health disparities. According to Healthy People 2030, quote, a health outcome seen to a greater or lesser extent between populations means that there is a disparity. It is also important to recognize the impact that social determinants have on health outcomes of specific populations. Some social determinants of health include quality housing, access to healthy foods and beverages, access to quality education, or just education. And we know that education affects our access to jobs, the type of jobs that we can have, the type of wealth that we can build based on the jobs that we have, housing, the safety of our environments, to name a few. Now let's turn for a moment to our uncertain times. We are in the middle of a pandemic and social reckonings, both of which are health issues at their core. Both the pandemic and our social unrest have rapidly shifted governmental policy at all levels and has brought us face to face with ourselves. As Christians, we understand and interpret the current events as prophetic. But do we also recognize our prophetic responsibility, our part to play in the crisis? And no, our part is not to take strong opposing political positions, turn on our brothers and sisters, and forget whose we are. Our responsibility is to do what we have been called to do as the final events of Earth's history unfold before our eyes. According to our Gospel Commission, Revelation 14:6, we are to preach the everlasting gospel unto those who dwell on the earth, to every nation, kindred, tongue, and people. You see, the pandemic, the Greek prefix pan meaning all, everything, or all members of a group. Yes, the pandemic and the social unrest coming to the forefront in the US and reverberating throughout the world is the source of our uncertain times, isn't it? But it is also the opportunity we've been waiting for. It is our biggest opportunity to use the health work as the opening wedge to other truths, as it was intended. No, I did not forget that I mentioned health disparities. Health disparities exist across many population characteristics. However, the racial and ethnic health population characteristics is the key health disparity type that connects the pandemic to the social unrest. You see, those most likely to contract, become ill, which is more morbidity, and die, mortality from COVID-19 are racial and ethnic minorities because they largely occupy service jobs where they come into contact with many people throughout their shifts. They cannot afford to take time away from these jobs because these jobs are primarily low paying and do not offer a lot of paid leave. They have less access to health insurance, so they delay or may not seek treatment for symptoms of the disease of COVID-19. And they may face bias in diagnosis and treatment of the disease, even when they do seek treatment. And if you'd like to see a little bit more about these disparities, COVID-19 health disparities, you should look at the work coming out of the Centers for Disease Control and Prevention, as they've been putting out reports on disparities in COVID-19 incidence, mortality, and morbidity. Similarly, those largely calling for social justice and equity are also ethnic and racial minorities. The policies that exist or are noticeably absent when it comes to inequities in the areas of housing, access to healthy foods, quality education, which, as we know, affects the type of jobs we can get, the wealth we can have, and the housing, are really based on racist ideology. And they are responsible for those health inequities that we see, that we study, that we work to reverse. If you'd like to see a little bit more about how social determinant of health, as we call them in public health, when you really break it down, is really a policy that exists that erects a barrier and maintains a barrier to having a more healthy life for certain groups, usually on the basis of race and ethnicity. I encourage you to look at Richard Rothstein's book, The Color of Law. And in that book, he details how racist policies are responsible for the housing, education, wealth inequities, all directly tied, as we know, to both our physical and mental health. So now our commission, according to Revelation 4:6, is to preach the everlasting gospel unto those who dwell on the earth, to every nation, kindred, tongue, and people, a multicultural, multi-ethnic, multilingual people. Even God in Revelation focuses on race and ethnicity, the same two population characteristics at the heart of our health disparities, and our disparities in COVID-19 infection rates, mortality, and morbidity. So how do we create health in uncertain times? Well, we address policies and practices that are at the root of racial and ethnic health disparities. By so doing, we address people's basic needs according to Maslow's hierarchy of needs, and really Jesus' strategy while on earth. He healed, addressed the physical and mental health needs of people, and then he fed them and preached. He fed them and then he preached the gospel. So he addressed physical, mental health needs, fed the people, then he preached. Okay, because he knew they wouldn't hear him if their physical needs were not attended to. So we need to address those physiological needs, those physical needs first. The health needs must be addressed before the higher level needs, that psychological need, which would be the gospel and the other truths, can be met. There's no shortcut, really. There's no other way around it. We must address those things affecting people's health. We are at a crossroads, I believe, a really critical juncture in Earth's history and also prophetically. So let us remove the barriers that are preventing people from hearing the gospel. They can't hear the gospel when those who seek to preach to them will not be their allies, will not fight to dismantle the very policies that affect their daily lives, their health. both physical and mental health. Many of us have been doing just that for years in our various roles. And when I say just that, I mean we have been working to address the policies that erect barriers for those seeking to live a full life and to achieve health equity. Maybe you've identified a troubling statistic that you have worked to improve and eliminate in your work setting as it relates to health inequities. Maybe you've researched and published on those policies that create and maintain health inequities, or you've spoken up when the opportunities arose, or even created your own opportunities to speak up about the need to address health inequities. You've created health in certain times, and in uncertain times, you must triple your efforts, because the Lord our God is even at the door. Thank you so much for spending the time with me today. And I pray that God will continue to give us the foresight and the courage to create health in these uncertain times. Thank you so much, and may God bless you.
I'm so glad that you could join us for this panel discussion with such interesting women. Today, we're going to be talking with Dr. Jennifer Veltman. She's an infectious disease specialist. She's the chairman of the department at Loma University. She has her MD from Wayne State, and she did her internal medicine and pediatric training at Detroit Medical Center, and her fellowship in infectious disease at UCLA. Also, we have Amanda Maggard. She's the CEO of Advent Health, Zephyr Hills, and Dade City Hospitals in Florida for the last 3 years. She has her MBA from Webster University and is a fellow of the American College of Healthcare Executives. Welcome. And we have Dr. Kathy Hayes-Arkt. She has her MD from Loma University and her specialization in obstetrics and gynecology, which she finished at Stanford University. She's been working at Kaiser Permanente in Riverside for the last 30 years, and she's well-traveled with mission trips to Nepal, Micronesia, Tanzania, and Ethiopia. So welcome, ladies. My first question is, the pandemic has just been the definition of uncertainty. And Amanda, let's start with you. You're head of a hospital. You had to secure protective equipment. You had to deal with a critical drop in patients to your ER in your clinics who weren't ill, and then the pandemic wave of COVID. How did you face that kind of uncertainty?
Yeah, it's a great question. It certainly has been a challenging year, the most challenging year I've ever experienced in my healthcare career of almost 17 years. And you know, I would say I really did rely more on my faith than I have at any point in my career. And one of the biblical lessons and stories that I've really relied on a lot, even before COVID, but some other challenges I've experienced over the last year and a half, has been the story about the children of Israel going through the desert and how God provided just enough manna for them every single day, and that they had to learn to rely on Him to provide for their needs one day at a time. And also how on Fridays, He had them to collect enough for that day and for Sabbath so that they could have that rest. And then that rest and trust in Him was just as important as their work. And as we began to go through COVID this spring, that was a lesson that I reflected on for myself and shared with my team, that we had to rely that God was going to take care of our needs that one day at a time, and that we also had to take the time to rest, and that rest was just as important for us as our daily work.
That's so true. Now, there's just been so much stress chronically in your staff. When you're running a team, how do you help your team manage stress?
It definitely has been a challenge. And we spent more time intentionally early this summer after we got through the first wave of COVID. That first 90 days from March until June was very stressful. Ironically, we didn't actually see our peak of patients until after that in July. But the mental and emotional stress of the uncertainty, the constant changes as we were learning more about the virus and changing things with our policy, as we were working to quickly acquire enough PPE, there was a lot of fear and anxiety in those first few months. That's when I think the emotional needs for our team were the highest. And so we very intentionally spent time. We started with our executive team debriefing. We pulled in our chaplain team and really debriefed and talked about what have these last few months been like, what's been the best, what's been the most challenging, and really pulled together and rallied as a team. And then we cascaded that through all of our departments. We did it for our leadership team, and then we did it individually by department, where we really tried to minister to their emotional needs and give them an opportunity to talk through that. One of the things that we did as well is really communicated our employee assistance program resources. And that's one of the things I'm excited that Advent Health is continuing to invest more in for emotional and mental health for our team members, because we have seen that need rise around the country. I think the latest statistics will indicate that 1 in 3 people is experiencing depression, and that's increased this year. And so we've tried to just be open about it, to talk about it, to take the stigma away, to share things that we ourselves have struggled with, and have the support of our chaplain team available.
So, Dr. Veltman, one of the difficulties with this particular virus is it's been unknown, and that uncertainty has just been creating a lot of difficulty. What do we know now to best protect ourselves, our church, and our community?
And very early in the virus, I think all of us infectious disease doctors, at least, recognized that it was a respiratory virus that was transmitted through the air, and that masks theoretically would be helpful, but originally masks were discouraged because of concern of the supply chain not being stable. But that got, I believe, misinterpreted and miscommunicated to make people think that infectious disease experts were suggesting that they wouldn't be helpful. So just wanted to clarify, I think that we all recognize that masks are beneficial, but didn't recommend them when they were really needing to be prioritized for healthcare workers early. Now, as the supply chain has stabilized and people are getting so creative, I should actually have my mask that I made back in March, but I cut up some old t-shirts and made some masks for my family with my sewing machine. It's very fun experience to do with my kids. But now as people are getting more creative and learning how to sew and really delving deep into their creative inner seamstress, we don't have quite the shortage of masks anymore. But now that the supply chain is more stable and there's a lot more masks out there, I would say wear masks. Definitely not unknown anymore. Do it, wear masks. I also, at the beginning, we were not sure if it was spread before symptoms or by asymptomatic people. And now we know with certainty that yes, it is spread by people who do not have symptoms. So that just makes this, I think that is the single most difficult thing to deal with this virus, because typically if someone's sick, they stay home, and that really disrupts the transmission cycle. But with this virus, that doesn't work. And so you have to therefore assume that people who are outside of your immediate family may or may not have the virus. And I don't like going around being everyone's social police and deciding did you do a risky activity? Did you do a risky activity? I that's just exhausting to me. I don't want to sit and nitpick everyone's social activities for the past 2 weeks and decide if they were good or not. So I personally just treat everyone like they have coronavirus. Just make the assumption that everyone has coronavirus and I'm going to like act accordingly. So for myself, I only interact with people who are outside my immediate family outdoors with masks. So if you do not live in the house with me, I will see you outdoors with masks. And indoors, it's impossible for me not to interact with some people indoors because, I'm an infectious disease doctor and have to go to the hospital and see patients. But I see our institution at least putting layers of protection on behalf of the healthcare workers. So when we see inpatient hospitalized patients, all of our inpatients have been tested for coronavirus, and then we wear masks. And in the outpatient world, we are seeing all the patients with a mask and a face shield and trying to limit the amount of exposure time, having short visits and staying as socially distanced from them as possible, and really limiting their amount of time in our waiting rooms as well. So when it's unavoidable for me to interact with people indoors, I don't rely only on the mask. There also needs to be like another thing as well, like the face shield, distance, the inpatients being tested, some other thing as well, because we know that masks, while they're protective, they're not 100% protective, and they're part of a protective bundle or a protective package. You need that plus something else.
Now, one of the sort of frustrations with this is that it feels a bit like churches and gyms are being picked on.
Mm-hmm.
Is there something about working out and church, perhaps singing, that puts us at risk of transmission more than, say, the grocery store?
So in the grocery store, you are usually just having these short exposures with people. You pass them in the aisle, you like pay for your food and you get out of there. Like I don't sit and have a 15-minute, 20-minute conversation with the checkout clerk, no matter how nice she is. It's like, here's my credit card. Thanks. See you later. Bye. And that's probably my longest interaction with anyone at the grocery store. There's the big plexiglass divider also at all of the Southern California grocery stores, at least, that again gives me another layer of protection, the plexiglass, plus we're both properly wearing masks. And if the grocery store worker is not wearing their mask properly, if they're down by the chin or whatever, I stand back and politely ask them to put it back up before I'll go through their line. So there are layers of protection and very short exposures in the grocery store. In the church, a lot of church services are 1 to 2 hours long, at least my church is, and you're sitting by the same person having prolonged exposure, and then if you add singing, which again aerosolizes like a lot more viral particles than not talking or saying anything, then that increases the exposure a lot. So I think that there are a lot of creative ways that churches can meet that decrease the risk of transmission. And I don't think that, at least this is my interpretation, I don't think that it's so much that like religion or church is being targeted. It's just the physical transmission dynamics, which are inherent in the way that American churches are set up. That's the part that is concerning to public health officials. Like many health officials that I've talked to are church-going people themselves, and they want to go to church too. Yeah, like the public health officials I've talked to, like they're most of them are very religious individuals as well. It's just the occupying a crowded physical space for 1 to 2 hours is a really risky activity. And so some ideas for church families to continue to meet together and have fellowship, because, fellowship is so important. If the church leaders could separate the church congregation out into small little church pods and have volunteers to host pods in the backyard and have, socially distanced little family groups in pods, and then broadcast the main message during that time. I think you could split the church up into much smaller, more distanced locations and still meet and commune with each other, but decrease the risk and do those in people's backyards with masks. Our church has been having the church service outside, socially distanced. Immediate family members sit together outdoors. Everyone has masks. If you don't wear your mask properly, you're asked to leave by the church elders. And there's at least 6 feet separating the family groups from one another, and then no singing for right now.
It's hard for church, isn't it?
Yeah, it is. It really is. So there's things that we can do to bring each other together without killing each other. The intention is to help each other, right? To grow with one another in Christ and edify each other and help each other, not to hurt each other and infect each other and damage each other. It's not like you're intentionally hurting others, but you can. And that's the real hard thing.
That's awesome. Now, Kathy, you dealt with this pandemic on a more personal level, in that your mom was in the hospital, not with COVID, but that created a lot of difficulties. Do you have some analysis from that perspective?
Yes, my mother was in the hospital for over 2 months and underwent major surgery and had multiple complications. Most of the time we could not visit her. She was in Maryland with a high COVID load when this started in May, and they put her into an ICU carved out of the recovery room, and that was the clean ICU because there was no COVID in those patients. However, being the ICU, there was no windows during those first 8 weeks she was there. And she had a hearing loss that was exacerbated by taking high-dose Lasix. And so hearing was an issue for her. And ultimately, she got a tracheostomy. She couldn't talk well. So and then the worst part, which was what Merida was alluding to, was that we could not visit. It was very rare for us to go in there. And that was basically when she lost the will to live, to give her a way to express herself. So and family was a huge thing for my mother, as for many patients. And she was so cut off. We were extremely reliant on technology and staff. ICU nurses obviously are very busy. She didn't need a lot of critical care, but the nurses were still busy with other patients. So we relied on the chaplain to help. The best thing we found was if there was somebody who had the time to read family texts to her, and she hated her cell phone, and we were so grateful she had it with her. There needs to be somebody who can make sure the patient's electronics are up and running. If she lost her charger, so I begged the nurses to find a missing one in Lost and Found. We begged the chaplain every day to go up and read texts. And then to try to find time for the nurses to do Zoom time with the family was a stressful thing at times too. And they really tried hard, and it was good. But to time that when other families available or the patient's not drowsy was sometimes a challenge. So I thought it would be helpful if, and I know you have to limit the number of people in the hospital, but somebody who can be devoted to helping family connect, somebody to keep sure the electronics are up and running. I found out from a relative, you can get these ear things that are earphones attached to a microphone, and that was able to help her to communicate. We used a whiteboard or notes to hold up so that she could read, and then she would write to us when she was able. And then one of the things my niece suggested, I didn't realize there was a patient experience department, and they were helpful. And we sent up a little cheap radio so she could hear music, but they probably could have helped with that. And my nurse also suggested, which I think is good, we sent food up to the staff. I know doctors will do anything for free food, and I'm sure nurses will too. So sending up coffee, cookies, pizza, even granola bars is appreciated. That was our experience, and that's more something the hospital can do and absorb less time from the staff. And one last thing, somebody who can go down and pick up the things that we dropped off, because they wouldn't let us upstairs, and the nurses were too busy, and security sometimes would and sometimes wouldn't carry stuff upstairs. So that's helpful.
Yeah. No, thank you for that. That shares with others who might be having that kind of dynamic some ideas too. Now, Amanda, we've just heard a talk about healthcare disparities. How do you assess for disparities in your own hospitals? How do we deal with that?
Well, I'm really pleased that Advent Health has actually named recently a new Chief Health Equity Officer. His name is Dr. Ulrich Simmons, and he has a passion around this work. He's a general surgeon by trade and is the Chief Medical Officer for one of our hospitals. And because of his passion around it, and as the headlines have shown, there's an increasing need for us to dig in and understand what are the health disparities. Advent Health named him to this role, and so he's going to start leading that work for us as a system and helping us better understand the data of patients that we care for currently in our hospitals, as well as helping us look at the data from patients just generally in our community and what are the health needs out there and health disparities that we need to work to overcome.
I think that's so important. I've been watching each field as they, emergency room, an article would come out and saying there are delays. And finally, an article came out in pediatrics, and I had to take it personally. And you really begin to say, we have to assess the data or we don't know how to fix it. And so I think that's the place to start. So Dr. Veld, your team must have had quite a bit of stress with the arguments over science and the disregarding of science that's been done. How, as a leader, do you deal with misinformation?
I pray for the people. I think I've come to the point of realizing that I can't fix everything and solve all the problems myself, and it's my responsibility to be a diligent worker, stay up to date on the latest information, to provide what I feel is the highest quality scientific information that I can. But there are people who, for Plaquenil, for example, when that Plaquenil was being discussed in May, everyone needs to be on Plaquenil, and people who were landscapers or engineers or school teachers or not in the medical field at all were just bombarding me on social media we need Plaquenil. To me, I just think if our church was building a bridge and the engineer said this is how this bridge needs to be constructed to support X amount of weight, that the landscaper and the grocery checkout clerk and the physician are not going to come and pick that apart and say no, you need to put that rail over there, and you need to use this kind of cement. You're using the wrong kind of cement. You need to mix it with this amount of like not 60%, 40%, I'm not going to go and tell the engineer what percentage of like water or tar or whatever is in cement. I'm not going to go and tell him like you're doing your cement mixing wrong because I looked it up on Google, and you know, someone who lost their engineering license is saying that this is the kind of cement that you need to use. Like, I'm just gonna trust that they are an engineer and they know how to mix their cement. And so I feel like there are some doctors out there who are not infectious disease doctors, who are like radiologists and eye doctors, and they're saying like hydroxychloroquine is the thing. And I used hydroxychloroquine at the beginning because we, you know, at that point we didn't know it in March, and we thought that there was a reasonable mechanism of action, so we used it for a month. But when credible scientific information came out, we stopped, and we evaluated the literature as as scientists, and said, you know, this seems to do more harm than good, and we're not going to continue. Originally we thought maybe this would be helpful, but we learned it's not. So I've tried to explain the process that I went through to people, and I try to say that, you know, I did critically evaluate the literature, and this is my take on it. But when they start nitpicking me and tried to say, well, the Henry Ford Detroit article says something different, and you know, I'm from Detroit and I know all those people and they're good people, and but that's not as credible of a study as a randomized control study. When they people who are not in medicine, they just don't understand that, and so at some point, I don't know, I just kind of leave it alone and hope that if they get sick, they're going to see a credible physician who does their due diligence to sort through the literature.
Now, Kathy, you've been on several mission trips. What do you think the lasting effects of medical mission trips are or can be, and how can we make them better?
I've thought a lot about this, and we have discussed it. I think there's a lot of one-off things that can be done. Cataract surgery, dental work, even just giving people eyeglasses. From an obstetrics and gynecology viewpoint, there's not a lot that I can do that's lasting without being hooked up to a hospital. So I worked with a mission in the Marshall Islands, and we would take teams for 2 weeks at a time and do surgery. And I was talking with the head of the group last night. We brought our own pathologist and cytotech to read pap smears and to read the minor surgery, the biopsies that we did. And then we could plan the additional surgery and do it as much as we could during those 2 weeks' time. So that would have a lasting effect. I have also been on mission trips where we treated people in a clinic without even running. We treated people in the library or on an open slab with a roof.
Wow.
And third world diseases, infectious diseases are no longer as prevalent. It's more first world diseases, diabetes and hypertension. So we would give people medication for a few weeks or tell them you need to go see your doctor. And I really struggled with the value of that, because in a month, you know, what we'd done probably wouldn't make a difference. They enjoyed seeing us, but I felt like, and I loved it. I felt it was just a wonderful experience for me and my children when I took them. But I felt like my money might have been better spent donating rather than going on my own.
Now, we just heard from Pam Townend about 10,000 Toes, which is a public health initiative dealing with treating type 2 diabetes in the Pacific. Will we begin to see more Adventist health message repackaged for today's audience? And Amanda, does sometimes the Adventist health message collide with the Adventist health system?
You know, I think that I was just in a meeting earlier today, and we were discussing that with COVID, we have seen so many lifestyle related diseases can further contribute, and folks that have those have worse outcomes with COVID. And so I think we have a unique opportunity right now to get our Adventist healthcare message out there, and that focus on whole person health. You know, we've seen that obviously with physical health and what we can do preventatively to live a healthy lifestyle and prevent obesity and things like that, help contribute to better outcomes with COVID. But also the emotional and the spiritual health. I mean, even in our conversation today, we've talked about the impact COVID has had in those areas. And so I think it actually gives us a unique platform to be able to get that message out there in a really, really relevant way right now that people are hungry to hear about. The second part of your question, I guess I'd ask for a little bit more clarity on.
Well, sometimes I feel like we're so busy promoting the emergency room and sepsis care and those sorts of things. Sometimes hospital systems aren't very good at promoting preventative sorts of initiatives.
I think it's definitely a balance of both. You know, we want to have and need to have facilities and services that we can care for people when they need it at those critical levels and promote what we have that's available. But certainly on the front end, helping to get the preventative message out there. I know here locally, some things that we've done on the front end is we have a number of wellness centers here in the Tampa Bay area, including one right here in Zephyr Hills that we promote. We have healthy eating classes. We have exercise, obviously, and trainers. We've partnered with some of our local schools to provide education on wellness, being active. So we've tried to do both and share the messaging around both. We've also tried to make sure that it's connected. So if we do have people that come in, for example, and they get newly diagnosed with diabetes here in the hospital, that we get them connected with our healthy eating classes, that they can continue that education in our wellness center with that team. So it is a combination of both. And certainly the business model sometimes conflicts in today's healthcare world. Sometimes the business model, if we do promote more on the preventative side, can impact us negatively financially. I think that's changing. And I do think that Advent Health has really taken a stand to say, you know what, even if it impacts us negatively, we're going to invest in the preventative side because that's part of our roots in Adventist healthcare, and it's the right thing to do for our communities.
That's awesome. I think that's a real advancement.
One of the things in terms of missions is the group that I worked with in the Marshall Islands was invited in by the Ministry of Health to handle their high load of diabetes. And they took the leprosy clinic across the breezeway from the hospital, turned it into a gym, kitchen, cafeteria, meeting room. They take patients from the islands in for 2 weeks at a time, take them to the gym, teach them how to cook healthfully, give them classes. And the cafeteria is there for anybody at the hospital and for the volunteers. Delicious food, vegan with fish. It was a wonderful ministry they have there.
That's great. Now, Kathy, you have a new project that sort of has a public health overtones. I think it's so crucial that girls get a good education, and I love to sew. Can you tell us about your new project?
I am helping out minimally as much as I can, though, with a group called Days for Girls. This is an international organization started 12 years ago. My first experience was somebody had brought about 400 sets of these reusable pads. They are reusable pad kits that we give to women who don't have these supplies readily available. And my first experience was somebody brought 400 of them with them to our group in Tanzania, and we distributed them to the girls at the secondary school where we stayed. I deal with bleeding almost every day of my life, and when women have abnormal bleeding, I think about women in other parts of the world who have no medication to control it and may not have adequate supplies or even adequate water. And so I was so happy to discover these and to discover there are over, I think I read, there's over 1,000 chapters around the world, and you can just look up Days for Girls and look at their map and find where you live and find a team or a chapter where you can go and sew. If you can't sew, you can cut fabric, you can iron it, you can apply the snaps, you can help or even just help assemble them. And it's really been fun. Nerida has joined us. Most of these groups are predominantly Mormon. The group that I've worked with, the Mormon missionary guys come and help. They're a little confused. Can I get a pad for my mom's kitchen? No, they're not heating pads. But it's a wonderful project. The girls are excited to get them. They are good for 3 or 4 years. And I looked up the numbers. They've helped 1.7 million women in over 125 countries. They think they've saved 115 million days of girls going to school, because girls in many parts of the world don't have adequate facilities or supplies and just stay in their room when they're on their periods. In Nepal, there's been some stories recently. Women will go to a separate shed. And I didn't even know this. I worked there for a couple of months. They go to a little shed, and a couple of women had been attacked by wild animals and killed. So not only do they lose that time in school, they can also be in isolating, dangerous situations. So if we can get them supplies and get the message of menstrual health needs around the world, it's very useful.
And I was really impressed with some data that's been coming out suggesting that when you give menstrual education and you give washable pads just before menarche, a few years later, after girls have started their periods, 15% more of them remain in school. And so I think that this is really an initiative for education as well. I think that's awesome.
And I read this great statistic last night. If 10% more women go to school, the GDP of their country goes up 3%.
Wow. Oh,
Pretty
awesome. So you're wiping out poverty too.
Sure.
Okay. The next topic that I want to talk about has to do with being working moms and having small children. This has always been a difficult issue. And Amanda, I'm going to start with you. You have the youngest kids at the moment. How do you manage both kids and working?
It certainly is a challenge, and every week and every month looks a little bit different. But my husband and I have 2 young boys. Our oldest is 7 and our youngest turns 4 next week. And my husband was a stay-at-home dad for a number of years, and now he's starting his own volleyball club. He's a high school girls volleyball coach. And so we've got both of our careers that we're juggling. COVID was definitely a challenge, because we went from overnight, our boys being in school and preschool, and overnight that wasn't an option anymore. And so we're fortunate that my parents live close by, so they helped us out. We had to juggle with a couple of our babysitters and get things lined up. And then both my husband and I also had to jump in different ways to be able to support the boys and being at home. I think what I've found for myself is that as a mom, it's still important that I have some time where I put my own needs first. And as moms, we're not always very good about that. Mom guilt is a real thing. But through COVID, I tried to still keep a priority working out a couple days a week, and that helped me manage my stress, both the stress I was feeling at work, but also the stress that I was feeling at home with all the different changes we were having to make. And I have found too that where I felt mom guilt before for other people helping out more with the boys, it actually has been such a blessing for them to have that much access to my parents or to their babysitters, that it's building up their social skills in ways that probably wouldn't have happened if they were just stuck with my husband and I. But it is a real challenge. And I think us supporting each other as women, connecting, is really important with that as well.
Just do the best you can, try to find childcare and look for a school that's got, if you're in Southern California, you can look for a school that's gotten a waiver. I know that some working moms have found learning pods where like they get together with 2 or 3 families and kind of decide they're going to socially isolate together and take turns watching each other's kids. So I think that there's a lot of creative solutions that have come out of this, but it's a struggle. It is a big struggle. I don't know how. I don't know how much advice I have, because I feel like what I have to say is more just empathizing that, yeah, this is a really hard time for working moms. There's a lot of difficulties that women who are working are facing right now. Absolutely.
My children are grown. I've been through those tough years. It's amazing when you finally get spit out at the other end. You look back and I feel so sorry for the young women in my practice still, because it's very, very challenging for the hours that we work. And what worked best for me was simply cutting that back as much as I could. And I was very blessed to be in a position where I could work part-time, and that really, and my husband was a stay-at-home dad too. He taught part-time at the university. So it was very much a blessing to have that help at home and part-time work.
I ran a campaign at my work when I was working part-time that everybody at work had to call it our day at home instead of our day off, because we'd get home and all of a sudden we'd be working harder than we had been at work. And so it just was a lot of work. I remember getting the advice that, and it's an interesting bit of advice. It goes counterculture to the lean-in philosophy. It was that that I should work 7/8 time. And people would ask me, what is 7/8 time? And I would say, it means that when my kid is sick at school and I have to go pick them up and take them home, that's my 1/8 that I'm not working. It means that I work a half day on birthdays and Halloween, because those are big days for my kids' lives, and it enables me to be part of them. And so those were some of the compromises that I made. Another bit of advice that I got for really young moms, one of my partners who had twins took me aside when I was pregnant with twins, and she said, before you start taking an antidepressant, I need you to drop everything and get 8 hours of sleep 2 days in a row. And that really made a difference in preventing depression when the kids were really young. And I think that that's one of those self-care tips that we have to take seriously.
I have one more piece of advice. My favorite line: the days are long, but the years are short.
It's so true. It's so true. When we're on the other end of it, we find it hard to imagine how we got through. So Amanda, courage to you. You'll make it through. Your kids will be great. And I think that that's another thing. You know, our kids have really benefited from us being working moms. They have medical stories to tell. They have insights of resilience and how to fit into tough times. And I think that's a real advantage too.
It's very true. And I think, you know, Narita, to your story about working 7/8 time, I think that's something for us as leaders to think about. How do we empower our leaders to think about that for their own personal lives? And, you know, some of the recent data that's come out over the last couple of months has shown how many women have dropped out of the workforce because of COVID. And it's really disheartening. And I think that the research will show that typically it is more often the mother than the father that's taking on that additional burden for childcare. And so how do we work with our teams, try to give that flexibility when we can, allow them to work from home, especially depending on their own health needs, if they're at risk or if their children are, and try to give as much of that flexibility to keep them engaged and part of the workforce long term, because we know that long term, having women in the workforce really does make us all stronger.
Yes. Ladies, thank you so much for your insight. I really appreciate your words of wisdom. I think you've given us all some good advice to think about.
My pleasure.
I'm so thankful for the health message of the Adventist Church, aren't you? Let's bow our heads. Dear Master Healer, please be with those who need your healing at this time. Please help us to share your truths about health with all of those around us so that we can live life more fully and longer. Amen. Join us next week when we talk about community. How can we create community in the middle of a quarantine and pandemic? And how do we create community that's inclusive of all the people that Jesus loves?